Welcome! The following presentation from Answers in CME is part of an educational activity titled Breaking Old Habits in Lung Cancer Detection, Expanding Screening Efforts Among At-Risk Populations. To access the full program and supporting materials, and to claim your certificate, please visit the activity URL in the episode description. This activity is supported through an independent educational grant from Merck & Company, Incorporated, Rahway, New Jersey, USA.
Hello, my name is Raymond Osaroyan. I'm a thoracic medical oncologist at the Baptist Cancer Center in Memphis, Tennessee, and director of the multidisciplinary thoracic oncology program in my healthcare system.
And I'm Michael Gieske. I'm a family medicine physician at St. Elizabeth Healthcare in Northern Kentucky and Southeast Indiana, and I am the director of our lung cancer screening program.
The benefits of lung cancer care are most observable in people diagnosed at the earliest of stages. Traditionally, the vast majority of people were diagnosed with stage 4 or 3 disease when cancer was kind of tough to treat effectively. Now we can identify lung cancer early enough that survival improves significantly. The 5-year survival rate among people diagnosed with early stage lung cancer is about 60-70%. For those diagnosed with late stage disease, it's actually less than 10%. So traditionally, it was only 15% of people in the United States diagnosed with lung cancer who were found at early stage. Now that has sequentially increased to about 1 in 4 people. So we are making progress, but we think we can do much better. The American Lung Association's 2024 State of Lung Cancer report indicated that eligible high-risk candidates were approximately 18% participating. The national screening rate also varies. Mike, can you tell us a little bit more about this?
This is the report that's put out by the American Lung Association every November, and it ranks the states from top to bottom, and there's a fairly wide range of uptake for eligible populations. The national average is 18.2%. Kentucky is 12th. We're at 21.4% where I work primarily. So we all have a long way to go to improve our screening rates, as Ray mentioned.
One of the key points is, of course, the places that have the highest per capita lung cancer mortality rates, unfortunately, tend to be at the low end of this geographical disparities plot here. There are several groups that are at highest risk for falling behind in access to this life-saving screening test. Racial minorities, people with lower household income, those who are less well-educated. Black individuals in the United States have poorer lung cancer prognosis, in greatest part because of diagnosis at advanced stage. There's good evidence that screening works particularly well in these racial minorities. The problem? Under participation. So only about 1.7% of eligible Black people have participated, significantly lower than white Americans. We know that the heart of the lung cancer mortality belt of the United States is in the southern part of the U.S., which also tends to be much lower in participation rates, especially compared to the Northeast. Structured lung cancer screening programs are mostly prevalent in the Northeast and not as densely prevalent in the southern and western parts of the United States. Mike, can you tell us a bit about your work in Appalachia and St. Elizabeth?
What we did is we looked at the area of the country that has the poorest access, the highest mortality, and the highest incidence of lung cancer. And they all coincide with where Kentucky and West Virginia came together. And what we find out is it's not only geographic barriers, but cultural barriers that we had to address and overcome.
In the next session, we'll discuss the most recent lung cancer screening guidelines.
So who should be screened? Most organizations use the United States Preventive Services Task Force Guidelines, or the USPSTF. This is adults that are age 50 to 80 with a 20-pack year smoking history and that you have smoked within the last 15 years. CMS pretty much mirrors these recommendations, except they exclude adults that are age 78 to 80. Other guidelines include NCCN, and their guidelines are individuals who smoked for 20 years and they're aged 50 to 80. Some systems have also adopted the American Cancer Society guidelines. They did away with the 15-year quit rule, and the rationale for this is actually very good. We look at the second box down on the right. These are individuals that quit at age 60 to 64. And after you quit, you hit a plateau where the lung cancer risk does not go up. However, as you get into your 70s, you have a substantial increase in lung cancer mortality just simply due to the aging process after you quit. Lung cancer screening uses low-dose CT screening. It's a very low dose of radiation, 1.3 millisieverts. The procedure takes about 3 minutes. You have one breath hold and you're in and out of the machine, typically within 15 minutes. It's really the simplest screening test that we do. Screening is recommended to occur annually until the age of 80, or it's been 15 years since you quit if you're using an USPSTF criteria. They have a rider that says the health problem that substantially limits life expectancy or the ability or willingness to have curative lung surgery is an exclusion. However, while surgery is the gold standard of treatment, some patients aren't good candidates for surgery because of age or frailty, but they still could receive SBRT, which is stereotactic body radiation therapy, which can be curative as well. You assess the risk in their smoking history, their age, and then CMS mandates that we do shared decision making for the initial or baseline screen. And this shared decision making has to include discussing the risks and benefits. You have to assess their willingness to pursue abnormal findings, and you have to discuss smoking cessation or continued abstinence if they've already quit smoking. If the eligibility criteria are met, then ideally you refer the patient into a coordinated programmatic system to assure the most cost-effective and time-efficient follow-up care at the least risk to the patient.
I think one of the knocks on lung cancer screening is that it's a triple jump. Every other screening test is a long jump. How old are you? How much did you smoke? How long ago did you quit smoking? Makes it really complicated. Eventually, we will get to where we can simplify the eligibility criteria.
Thanks, Ray. Well said. In the next session, we'll discuss how to incorporate screening into clinical practice. There are a number of barriers to lung cancer screening. For example, there can be unequitable distribution of screening programs. There can be inadequate EMRs, inadequate smoking history, limited time for clinic visits. Nihilism is essentially a fatalism that lung cancer is plagued by. Lung cancer historically has been a very deadly cancer. So we're trying to get over that nihilism, going after it, catching it early. And even when we find lung cancer in the later stages, it's curable oftentimes now. This is one of the things that we've done at St. Elizabeth that has simplified our smoking history. Each time the patient's smoking history changes, it continues to update automatically until the patient's smoking history changes. Oftentimes in EHRs, there are prompts in the health maintenance that say whether a patient is overdue for their screening or whether they've met the screening. I certainly recommend a best practice advisory, especially for systems that are just beginning lung cancer screening. We also have a smart set, and this really simplifies the ordering. You get a drop down of the diagnoses. The most common diagnoses that are covered by really every insurance company out there is cigarette smoking, F17.210, and personal history of tobacco use, Z87.891. You open up the shared decision-making body and indicate whether it's an annual or baseline screen, and then it walks you through the different components of the shared decision-making, simplifying it. And when you do this into your progress note, you get the diagnosis and the tests that you ordered, and you get a customized entry in your progress note stating that the patient met the criteria and that they had the shared decision-making conversation. One of the things we've done to really improve our uptake and our adherence is our nodule review board. We have 3 nurse navigators that are present. We have a radiologist, a pulmonologist, and a thoracic surgeon. We review all of our lung-RADS category 4s, which are the high-risk nodules that we find, and also suspicious nodules that come in through the emergency room and through other channels that the radiologist tags or that are brought in by our AI software. And they're given a low, intermediate, suspicious, or high grade of suspicion, and then they're given one of these 5 dispositions. Sometimes it's just follow-up surveillance.
We've been focused on lung cancer screening, but we do CAT scans and x-rays for a myriad of reasons through the ER, pre-op, primary care clinics, and so forth. And not uncommonly, we find these lesions that the radiologist identifies, describes, and says this could become a lung cancer later on. These so-called incidentally detected pulmonary nodules are one very pragmatic way to do early lung cancer detection that uses the same infrastructure for decision making and triaging that a lung cancer screening program does.
Thanks, Ray. Well said. So another tool that we have is our quarterly report. And I think this is really one of the most integral components of our lung cancer screening program. We rank all 41 of our primary care sites and all 250 of our primary care providers from top to bottom, depending on what percentage of their denominator that they've captured. There are very compelling results from the National Lung Screening Trial and the Nelson trials, which essentially put lung cancer screening on the map. But there's really nothing as powerful as getting good homegrown data, and we'll demonstrate this in subsequent sessions.
The levels of participation among the screening eligible population in the United States are quite low. Because of the complexity of the eligibility guidelines, even those who know that they're possibly eligible for screening aren't usually certain if they would qualify. Many patients do not ask about lung cancer screening when they meet with their primary care providers for various reasons, again, including this idea of nihilism around lung cancer. So to correct these problems, we have to educate the population. We have to increase awareness, reach out through all possible media into our population, and really change the narrative from doom and gloom to the tremendous upside of a survivorship story, and to celebrate the fact that early detection, screening is a major part of that opportunity, the survival story. The reasons for patient reluctance, refusal to engage this discussion are varied and complex. As we said, there is a lot of stigma, there is a lot of self-blame. The people at greatest risk for lung cancer, socioeconomically disadvantaged, the less well-educated, racial minorities, these are people who have a fairly high level of distrust of the medical system in general. So in terms of how do we make this better, I think we need to get good feedback from our patients, our communities, their caregivers, in order to create culturally appropriate materials that can help us overcome the barrier to engaging the discussion about lung cancer screening. And in communicating, we do want to be respectful. And even when somebody seems to reject what we are recommending to go get screened, we should still remain positive and also leave them the opportunity to re-engage at a reasonable time interval, even if not ready at that point in time. Another area of challenge, of course, is the complexity of the tobacco history. People's ability to recollect how long they have smoked for is difficult. People start and quit and start up again and quit through stretches of time over the years. We should ask for permission to dig into the history. And if a patient is unwilling to do that, then we should be respectful enough to back off. We know that nicotine is one of the most addictive substances. Patients are not exactly happy about the fact that they smoke. They tend to be defensive. This is not a fault-finding exercise. We do not judge our patients because they smoke. We also, as part of that, need to acknowledge that smoking is the most important known cause of lung cancer, but it's not the only one. In the next and final session, we'll discuss interpreting lung cancer screening results and next steps in the care pathway. So a patient gets screened, the radiologist reads the low-dose CT scan, and from the American College of Radiology, we have a standard reporting format called the LongRads score that radiologists should use exclusively. It goes from 0 to 4. LongRads 0 means an incomplete test which needs to be repeated. LongRads 1 is a clean CT scan. LongRads 2 means there is a nodule or something, but it looks benign. LongRads 3 means there is a nodule which does not have all the features to call it benign, but is still probably benign. And then you have Longratz 4, which reveals suspicious lesions for lung cancer. This is split into subsets. What if the scan is negative? The recommendation with a negative scan is that a follow-up should be done 1 year later, another low-dose CT. One of the challenges we have seen is that approximately only 22% of people who have had a lung cancer screening test actually come back for the next annual test, which is a real problem.
With respect to smoking cessation treatment options, there's, of course, behavioral therapies and motivational counseling, which you can do in the office. There are structured programs you can refer the patients to. And, of course, there's pharmacotherapy.
Mike, how do you communicate results to patients, and how do you, as a primary care provider, ensure adequate follow-up?
We have 3 full-time screening nurse navigators that do an excellent job. They communicate the results to the patient, they direct them with their follow-up imaging, and they connect them with the providers that they're referred to. Our ordering providers can, of course, discuss the results with their patient, but we really advise them to hold off on ordering any additional scans or referrals until the Nodule Review Board has had a chance to review the results. At St. Elizabeth, we do a lot of lung cancer screens, but what's more important than the number of screens that we do is the results that we get. We found now almost 860 lung cancers since we've started our program, and the best news is that 65% of them have been in stage 1. As your lung cancer screening program evolves, you see what's called stage migration or stage shift. Historically, about 50% of lung cancers are found in stage 4. The blue lines indicate what happens in a screening program, and you found 114% more in stage 1 and 79% less in stage 4. And really the most impressive impact that lung cancer screening and a good incidental pulmonary nodule program can have is late-stage lung cancer has continued to decline. Early-stage lung cancers have continued to increase, and we're now finding more early-stage lung cancers as opposed to late-stage lung cancers.
You guys have done an incredible job at St. Elizabeth and really across the state of Kentucky. I think there are just a few things that we can wrap up with. One is that lung cancer screening saves lives. It is the screening test with the highest level of evidence to support it. Number 2, we as a healthcare providing community have to figure out how we will bring this life-saving discovery to everybody who stands to benefit from it. And then the third thing is, yes, indeed, there is some complexity about lung cancer screening. And now what we need to do is figure out how to make it as simple as possible so everybody can get it.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.